We are live.
A very good evening and a warm welcome from India. Today we are here for the AIOS IOC 2024 meet, the Asia Pacific Glaucoma Society Symposium, and the topic being the recent advances in the OCT imaging for glaucoma. I'm Dr. Subhav, I'm a host for this session, and I now invite our moderator, Dr. Devang, to take over the session. And with the same note, I welcome the chairpersons, the panelists, and all the speakers for the session. Over to you, Dr. Devang.
Thank you, Dr. Subha. So today we have this session on at the outset. We would like to thank ABGS and AIOS for giving us this opportunity to conduct this session on the recent advances on OCT. And we have our chairperson, Dr. Monisha, who is a clinician scientist in Singapore at SNEC. We have in our panelists, we have, I think Dr. Fang hasn't joined. Then we have our Professor Tanuj Dada, who is head of glaucoma services in All India Institute of Medical Sciences. We have Dr. Ronnie George, who is a senior glaucoma consultant in Shankar Nethralaya. We have Dr. Sushma Tejwani, ma'am, who is glaucoma head in Narayan Nethralaya. And we have Professor Pandav, sir, who is head of glaucoma services in PGI, and Dr. Sunita Dubey, ma'am, who is the medical director and head of glaucoma services in Shroff Charity Eye Hospitals. And with this, I would like to invite our chairperson, Dr. Monisha, to give a few words.
Thank you, Devang. So very warm welcome to all our panelists, our speakers, and also to the participants who've joined in from Zoom. So we're really happy to bring to you an excellent list of, a lineup of speakers, both local and international from the Asia-Pacific region for this Asia-Pacific Society Symposium on recent advances in OCT imaging for glaucoma, which is part of the AIOS International Ophthalmic Conclave. So for this session, we've included talks that ranges across the OCT spectrum from anterior segment to posterior segment, including OCT-A. And we've also included, in addition to understanding their use in diagnosis and management, also we've included talks on their use in OCT-guided surgeries. So I really hope it's an engaging session. And I hope everybody takes home with them insights of the recent advances and also a better understanding of OCT. So with that in mind, I hand over to Devang, our moderator again. So yeah, back to you, Devang.
You're muted, Devang.
To start with the session, I would first like to invite upon Dr. Monisha, who would be speaking on the clinical uses of ASOCT in glaucoma. Over to you, Monisha.
Okay, let me share my screen. All right. Okay, so good evening again, everyone. So I'll start off the session with anterior segment OCT. Okay, so this is a slide which shows the evolution of ASOCT from time domain to what we have now, the swept source system, which allows circumferential imaging, 360 degrees imaging of the anterior segment structures. Sorry. So what the CASIA or the 360 degrees imaging does is it scans about 128 cross-sectional scans in about 2.4 seconds, which encompasses the 360 degrees. And the inbuilt software of the CASIA facilitates measurement of what we call the ITC index, or the iridotrabecular contact index, which quantifies the extent of angle closure across 360 degrees of the angles. So in my talk on the ASOCT applications, I will also include briefly on the use of anterior segment OCT in geography and its potential use in glaucoma. So I'll start with a question that I'm often asked is, will ASOCT replace gonioscopy? So before I answer that, let's see what information can we get from gonioscopy versus an ASOCT. So with both modalities, you can see whether the angles are open or closed. However, there's some information that you can only be garnered from a gonioscopy, such as the ability to perform indentation gonioscopy, or evaluation of angle pigmentation, vascularization. There's some information that you can only get from AIOS-OCT, such as evaluation of iris thickness and contour, as well as measurement of the magnitude of the lens, such as the lens vault, and evaluation of interrelationship of the different anterior segment structures. So from here, you see that the information that is garnered from each examination modality is unique and they complement each other. Therefore, if available, they can be used concurrently for a more complete assessment of the anterior segment. Now, when AIOS-OCT was first introduced about 15 years ago, it was evaluated as an adjunct to gonioscopy, and it's been shown to have an excellent ability to detect angle closure. And now, as I've shown previously, with the ability to measure 360 degrees, we have the ITC index, which quantifies, so it gives us a quantification of the extent of angle closure, and this is really good for documentation and serial follow-up. And again, with the CASIA 360 degrees evaluation, we can not only evaluate peripheral anterior synechia qualitatively, but can also determine the extent of PAS. And this was shown in a paper by Lai et al., and which also showed good agreement with gonioscopy. Now, AIOS-OCT can also be used to obtain measurement of the lens in the lens vault, which is a measurement that quantifies the extent of lens that is located anterior to the anterior chamber angles, and it's been shown to be a better marker for assessing the role of the lens in angle closure. Now, with the CASIA 2, this is the newer CASIA machine. It has an inbuilt software in it, which is called the STAR 360, which in addition to providing all the different anterior segment parameters of the angles, anterior chamber, the iris, and the lens vault, it also has the ability to give measurements of the entire lens thickness. So AIOS-OCT can also be used to detect subtle subluxation in lenses. I guess more obvious subluxation can be detected clinically, but AIOS-OCT can be used just, on AIOS-OCT, you can see slight asymmetry in the images. And as alluded to previously, AIOS-OCT can also be used to assess variations in iris anatomy, such as thickness and contour. And it's also been used to subgroup angle closure based on anatomical factors. There have been many papers that have looked at this, and they found using hierarchical clustering that angle closure can be subgrouped based on anatomical factors alone into either thick peripheral iris or large lens, and in some papers also an intermediate group, which is intermediate between a thick peripheral iris and a large lens. So this suggests that some factors may be different in different individuals, and treatment outcomes may differ based on the underlying mechanism. And this is what Kyungrim's group, Kyungrim is one of our speakers today, they had looked at quantitative subgrouping, where they'd use hierarchical clustering to cluster pre-LPI images into those with shallow AC and large lens vault, and the other cluster, which is deep AC and plateau iris. And what they found was post-LPI, there was a significant increase in the amount of angle opening in the patients that were clustered to the shallow AC or large lens vault group, suggesting that outcomes of LPI may differ based on anatomical characteristics. The same group also looked at longitudinal study of post-LPI, but based on qualitative categorization of the pre-LPI images into different mechanisms, such as pupil block, plateau iris, thick peripheral iris, and large lens. And they found that across all groups, the ACD decreased and the lens vault increased over time. Angle widening was greatest at the pupil block group, and lens vault showed the greatest decrease in IOP, again suggesting that the outcome may differ based on the presumed predominant mechanism. Therefore, knowledge of these underlying mechanisms may help predict future changes in anterior segment parameters. Now, coming to post-intervention assessment. So this was a study, a randomized controlled trial, which is done in Singapore, where we compared phaco versus phaco GSL. And we performed the CASIA imaging both pre-op and post-operatively. And as you can see in the images, in the phaco GSL group, there was greater reduction in the circumferential ITC index, which means there was no more angle opening compared to the phaco group. Now, bleb morphology is an important indicator for assessing bleb function, and but it mainly relies on evaluation of external characteristics. It's very difficult to assess internal bleb structures, and that's where the AIOS-OCT comes in. So with AIOS-OCT, you can not only qualitatively, but can also perform quantitative assessment of the different internal bleb structures, such as bleb height, cross-sectional area, and height of the wall. And there have been many, many papers that have compared successful blebs versus failed blebs. And across all of them, the common feature for good filtration was the presence of internal fluid-filled cavities, low reflectivity of the bleb walls, microcysts, and a patent internal ostium. And this is just an imaging from a paper from Mandeep Singh's group way back in 2009, where you can see the differences in successful blebs and failed blebs, where successful bleb shows presence of microcysts, fluid-filled cavity, as well as lower reflectivity. Now, 3D imaging using Cassia has also been used as a predictor to predict future bleb function. So in the paper by Narita's group, they had actually qualitatively defined 3 different qualitative characteristics called stripling, shading, and cyst-like. And they found that the presence of stripling phenomenon at 2 weeks was a predictor for success at 1 year, whereas bleb height and bleb wall thickness were not significant predictors. Another paper from Matsumoto's group also looked at different parameters. They took 3D AIOS imaging. They looked at other parameters of the bleb, and they found that a parameter called the width of the filtration opening was significantly inversely proportional to future IOP at 1 year, which means the larger the opening, the lower the IOP at 1 year. AIOS can also be used to visualize position and patency of aqueous shunt, especially in those where the cornea is not visualized, opaque corneas or corneal edema. So you can find out why, so like for the example below, high IOP, corneal edema, tube could not be visualized. And when they did OCT, found that it was obstructed with the iris. And can also be used for patency position of tubes in past planar placement. And the picture above, actually, this was a patient with corneal edema, and we did ASOCT. We found that the entire extent of the tube was opposed to the cornea. So ASOCT, we know that retraction of AGV tubes can occur after surgery. And this paper by Lupili Park, they actually took serial measurements or serial imaging of the AGV tubes by ASOC, and they found that the greatest retraction occurred in patients with uveitic glaucoma and glaucoma following PK compared to the primary glaucomas. Now, bleb vascularity is another component that is evaluated, commonly evaluated for bleb. However, clinical grading is quite subjective. And so with the advent of ACT or OCTA, as in this paper, which shows that the ability to image conjunctival and interscleral normal vasculature, perform both qualitative and post-image processing quantitative parameters, there's perhaps a possibility that anterior segment OCTA can aid in the evaluation of post-trabeculectomy blebs. And this is what this paper did, where they serially evaluated bleb vascularity using OCTA, I think from pre-op to month 6. And what they found was that the greatest increase in vessel area occurred at month 1 post-trabeculectomy, and the findings were largely similar in chronic and acute eyes. And they found that, interestingly, the change in vessel area at month 1 correlated to IOP at month 6. So these were very preliminary studies, but they did provide information on the ability to effectively use some of the OCTA features to predict future surgical outcomes. And OCTA also provides a more informative adjunctive method for grading vascularization. So now with ASOCT giving us better visualization of the internal bleb structures and OCTA for bleb vascularity, is it possible to then use both of them to better assess blebs? And this is exactly what this paper did. This was published last year, middle of last year, from the Zongshan ophthalmic group, where they actually defined a quantitative grading system where they combined vascular and morphological features to see if they can be used to assess blebs better. So this was a cross-sectional study. So clinically, the blebs were graded using the IBAGS and the Moorfield bleb grading system. For ASOCT, they measured bleb height and microcyst structure. For ASOCT, OCTA, we know that OCTA gives us a lot of parameters. So what they did was they did a complex factor analysis, and they combined all these different factors into a common score called the multivascular model score. So like I said, this was a cross-sectional study, and so they had eyes that were successful and failed groups. So the success group, as expected, had lower IOP, lower vessel density, more microcysts, but there was no difference in bleb height. But interestingly, what they did is when they looked at diagnostic efficiency, they found that a combination of vascular and morphological features actually had the highest AUC to diagnose failed and successful blebs. And following the logistic regression, so this parameter called the vascular and imaging, vascular and morphological parameter is actually a derived parameter from the logistic regression. So based on their study population, so they found that with an AUC at an AUC of 0.92, the cutoff value of this had was correlated with an IOP of 15, and as you can see here, the values above that, the IOP actually goes higher. Prior to that, it's about plateau, and then it suddenly goes high. So what they suggest is maybe a parameter like this may be used as an early warning sign to see if it's impending bleb failure of bleb function, whether you need to intervene. So this is just from a cross-sectional study, but it does show, there's a lot of work that needs to be done in the future that maybe we can combine vascular and morphological features, maybe more useful for monitoring blebs. So what perhaps in the future, what we envisage is we can get one parameter similar to maybe a visual field MD or VFI or an OCT that can tell us, that we can monitor blebs. Maybe that'll be an exciting thing to look out for in the future. So in summary, ASOCT can be used as an objective method to assess the angles and to measure quantitative anterior segment parameters. It does complement clinical assessment in evaluating bleb morphology of vasculature. It can be used for evaluation of device, especially in cases where there is the cornea is opaque. And I think documentation is really important, not just for treatment outcomes, longitudinal evaluation, but also as a teaching tool, not just for residents, but also for patients, as an education tool for patients. And also, of course, this imaging documentation is better than just writing it out in notes, perhaps. And ASOCT is also useful when gonioscopy is not possible, as in corneal pathology, trauma, poor patient cooperation. So I'd just like to acknowledge Toon, Shumira, and Shimna for help with some of the slides. Thank you very much.
Thank you, Dr. Monisha, for this wonderful talk. And I think in the interest of time, we'll do the discussion at the end. And Dr. Sung is not there as of now, and we haven't received any recorded presentation of hers as well. So then I would like to call upon our next speaker, Professor Pandav sir, who would be speaking on OCTA in glaucoma. Over to you, sir.
Thank you, Devang. Let me share my presentation. Okay. Can you see the presentation?
Yes, sir.
All right, so I'll put it in the screen mode. Okay. So thank you once again, AIOS and APGs, for this opportunity. I don't have any financial interest in any of the technologies that I'm going to mention. We know the blood flow is important for glaucoma point of view, and we have seen that reduction in blood flow into the retina or the optic nerve actually is implicated in the pathogenesis of glaucoma. And we also have evidence to that in the EMGT, that the low perfusion pressure was a significant risk factor for glaucoma progression in that study. Unfortunately, we don't have a perfect way to measure blood flow. So there's a kind of a lacuna there, but OCT angiography is kind of filling that void. Though it doesn't measure the flow directly, but it does give you a indirect measurement of the ocular perfusion. And this is emerging a tool that can provide us a non-invasive, high-resolution imaging of the vasculature of the retina, choroid, and optic disc region. And this gives us both qualitative as well as quantitative assessment of the optic nerve head vasculature, and that can be used clinically to monitor these cases. The glaucoma diagnosis, we know, and as well the monitoring is important. And by and large, the way it's done is that we have a clinical diagnosis, and then that is supported by some functional or structural tests. The functional test, the gold standard is visual field, as we know, and the structural test, OCT, is the gold standard. So both of them are used together to make an assessment of the diagnosis of progression. Now, in addition to OCT, now we also have an OCTA, which is actually complementing OCT and the visual fields in that sense, to give another dimension about the vascularity or the circulation of the optic nerve and the retina. So both all these three, they actually get together very well. So if you look at the OCTA and glaucoma, it's, as I said, it's a non-invasive assessment of optic nerve head, and on OCT in the peripapillary area or the circumpapillary area, we can see that there could be, the density of the capillaries actually decrease, and the density can be calculated by taking in a certain image and look at how much is the area occupied with capillaries and how much is the total area, and that gives us the ratio, gives us the density, and this can be done with the built-in software in the machine. The area of the vascular density decline or the circumpapillary, capillary dropout, it corresponds with the area of nerve fiber layer on OCT. So there's a correlation there. So if you look at the OCT in glaucoma, the vessel density and the optic nerve, the flow index, it was seen that is reduced in glaucoma patient as compared to the healthy eyes. And that kind of suggests that OCTA could play a role in glaucoma. So the role of OCT in glaucoma is the area of vascular density in OCT is coincide geographically with the structure and the functional loss of the measured by the OCT in the nerve fiber layer. So if you look at the structure function correlation in these eyes, so this is a 56-year-old female patient who was diagnosed as NTG, and the IOP was maintained with one anti-glaucoma medicine, and clinically no progression was noticed in the follow-up of 9 to 10 months. So you can see there's a rim damage in the spironasal quadrant in this patient. And if you look at the OCTA image, you can see the corresponding quadrant shows dropout areas in the capillary. And if you calculate the total vascular density, is like 43.1% here. And if you look at the OCT, then again the same, the superiorly and the spironasal quadrant are showing thinning of the nerve fiber defect as well, and the visual field is showing corresponding visual field defect in the inferiorly. So it makes a very good correlation between all the methods of examination, the clinical examination, the OCT, and the visual field examination. And that was kind of an obvious glaucoma, but even in early glaucoma, if you can see here, on the right side, you have an OCTA. It shows the reduction qualitatively as well as quantitatively, but even qualitatively you can in the lower temporal quadrant, and same is actually seen in the visual field. The corresponding field effect is seen in the visual field as well. The other issue is, so can it help in the early diagnosis of glaucoma? Now, if you look at the whole image vascular density in the circumpapillary and the area, and the nerve fiber thickness in differentiating health glaucoma suspects, so it actually they're quite similar. They're about the same in diagnosing glaucoma. And the OCTA measured peripapillary vascular density and the peripapillary nerve fiber layer in OCT is comparable in distinguishing mild glaucoma eyes from the normal control. So it appears that OCTA can actually help pick up the disease early. The OCTA measurement also detects glaucomatous changes in macular vascular density in eyes without evidence of change in GCC. So this is important because if you're doing the macular OCTA, that might be able to pick up these changes earlier than the OCT. So there's a good discriminant ability of peripapillary vascular density than the macular vascular density, and that is also kind of there in the literature. So the concept is still kind of developing. Other issue is that patient 59 years old, male patient POAG, and IOP is maintained with 2 anti-glaucoma drugs, and the visual fields done over this period of time didn't show any progression on visual fields. But if you look at the nerve fiber defect in the upper images, so you can see after during this period there is some decrease in the nerve fiber layer thickness in the spherotemporal quadrant, and same is also visible in the OCTA image, and there's some decline in the vascular density is also seen over this period of time. So that means here both OCT A as well as the OCT is able to detect some progression before it appears in the visual fields, So we had a study on 64 eyes, and where we did the OCTA visual fields, and after an average follow-up of 11 months, if you see the number of eyes that progressed on different modalities, the visual field shows progression in 22% of eyes, OCT in 28% eyes, and OCTA showed progression in 36% of the eyes. So it appears that OCT and OCTA both are able to pick up more progression as compared to visual fields, and OCTA perhaps looks like it's even performing better than OCT, at least in this limited sample size. So in OAG eyes, the rate of longitudinal circumpapillary capillary dropout, capillary density loss was significantly associated with visual field progression, regardless of the glaucoma stage. So there's that OCTA is useful. Others might be able to predict visual field changes in future. And that also appears to be true. The glaucoma patient with microvascular dropout on OCTA showed significantly more chances of visual field progression later on. So that means here also it basically says the same thing, that OCTA was able to pick up some changes early, which later on appeared on visual field as well. So that again is a pointer towards that OCTA could pick up these changes early. Then if you look at the OCT versus OCTA, because both modalities appear to be good in picking up progression. However, the problem with the OCT is that it reaches a floor effect earlier than OCTA. So if you have advanced glaucoma, then the OCT kind of reaches a, the bottom line beyond which it will not show any change even if the disease is progressing. But the vasculature of the retina, peripheral retina, it continues to change even after that, and that can be picked up with the OCTA. So in that sense, OCTA could help, could complement visual fields in monitoring glaucoma when the disease is advanced. To summarize, OCTA is a non-invasive tool to study retinal vasculature and has several advantages. It correlates with modalities for diagnosis of glaucoma to pick up progression early and can be useful in monitoring progression even if the glaucoma is in advanced stage. Thank you very much once again for the opportunity. Thank you.
Thank you very much, Dr. Pandav. Very interesting talk on OCTA. So Dr. Kyungrim is not with us, but she sent her slides, her recorded slides. So before we play her slides, I'll just like to introduce Dr. Kyungrim. She's a professor of ophthalmology at the Asan Medical Center of the Ulsan University in Korea. So Dr. Kyungrim's research interest is angle closure, pseudoexfoliation, glaucoma imaging, and she also does basic science work related to gliosis and glaucoma. So I think we can play Dr. Kyungrim's slides on the use of OCT in glaucoma diagnosis and monitoring.
Hi, this is Kyungrim Song from Asan Medical Center, Korea. I'd like to express sincere thanks for the invitation to the excellent symposium. Today, I'll be briefly talking about the use of OCT in glaucoma diagnosis and monitoring. Like everybody does recently, I asked ChatGPT-4, is OCT mandatory for diagnosis and follow-up in glaucoma? While OCT is not mandatory for glaucoma diagnosis and follow-up, it is often recommended and used as a standard of care in many clinical settings. And OCT may be very useful for detecting early changes that are not yet visible on examination. The decision to use OCT should be made by an eye care professional based on the individual patient's needs and the clinical context. Those were answers from ChatGPT-4. Whatever he or she or it says, OCT is widely used for glaucoma patient care, and more ophthalmologists are relying on OCT for glaucoma diagnosis. ONH and RNFL examinations are still the reference standard for glaucoma structural examination, but these examinations are limited by they do not provide quantitative information. In the meantime, OCT measured RNFL assessment provides objective and quantitative information, and it also allows to examine another important targets for glaucomatous damage, such as macula and deep layer ONH. Further, such quantitative outputs are categorized into levels, abnormal, borderline, and normal, and it supports the doctor's clinical decision. Along with the wide clinical use, the research related to OCT is exponentially increased. So what OCT exactly do for us? First, it helps us to differentiate normal from abnormal in terms of structural aspect. Second, it provides clue that such abnormality is due to glaucoma or not. Finally, it shows glaucomatous damage is progressive or not. Usually, it is not difficult to say ONH is normal and this ONH is abnormal, but sometimes it's tricky. Some of the glaucoma experts assess this ONH is normal, but OCT shows RNF thinning in the inferior temporal area, which corresponded well with the superior lesion stat in the visual field. OCT is especially useful for diagnosis of glaucoma in the small optic disc. Small optic discs usually do not have optic disc cupping. This patient also have elevated intraocular pressure and subsequent RNF thinning, but does not have optic disc cupping. But OCT measured RNF thickness nicely shows thinning in the RNF thickness, and which corresponded with the visual field defect. Next, OCT allows differential abnormal findings are originated from glaucomatous damage or not. This patient have been treated with glaucomatous medication in the local clinic, and OCT measured RNF thickness shows abnormal thinning. But we may figure out this abnormal thinning is located mainly in the macula, which corresponded with the central visual field defect, which is not the feature of glaucoma. We assume this patient had dominant optic atrophy. This is also a very interesting case. He has been treated with glaucoma for a very long time, which is RNF defect in the OCT. But when you look at the macular ganglion cell thickness map, you may know that hemi defect, which respect vertical meridian, and his visual field a little bit confusing, but in the repeated exam, the pattern seemed to respect vertical meridian. And we could confirm his old brain region in MRI, and so this case revealed OCT macular assessment was helpful for differential diagnosis of glaucoma from brain lesion. This patient was suspected of glaucoma because of RNF thinning in the superior temporal area, but diagnosed as optic disc intrusion. Similar case is shown here. We could diagnose optic disc intrusion by examining the cross-sectional image of the optic nerve head, which showed vertical hyper and hypo reflectance, which was caused by calcium deposit. This deposit can obstruct exoplasmic flow and subsequent RNF atrophy, which may mimic glaucoma. Finally, OCT can aid the determination of glaucomatous structural progression. We absolutely are still using optic disc and RNF examination, which shows the feature of neuroretinal rim things becomes thinner and RNF defect becomes wider. However, this change in detection is substantially dependent on the examiner's subjectiveness. Therefore, quantitative outputs are even more important for progression detection. Serial OCT RNF examination shows the change as red or yellow color, which exceeds the cutoff value derived from reproducibility error. And this eye had perceived RNF thinning in the inferior temporal area, which corresponded with the deterioration in the superior visual field. During 6 years, this patient optic disc shows slight thinning in the inferior temporal neuroretinal rim, but it is very hard to detect this change for most of the ophthalmologists. However, macular ganglion cell thickness map excellently shows progressive thinning. This case also demonstrates the utility of ganglion cell thickness map. This page shows no change in the RNF thickness map because RNF thickness already reached the measurement floor. but ganglion cell thickness map shows progressive thinning in the papillomacular bundle area, which corresponded to the central visual field progression. Definitely, OCT has several limitations. First of all, its output is heavily dependent on image quality. If the image quality is bad, the quality analysis output is completely useless. So we all know that it is very difficult to obtain good image quality in some situations, in some patients. Another caveat is that its normative classification is derived from several hundred persons' data. Hence, some incorrect classifications are produced by the optic disc configuration, like optic disc tilt or rotation. We do hope recent effort to individualize glaucoma change detection using artificial intelligence would overcome this issue. Absolutely, careful examination of the optic disc and RNA field are superior to OCT exams for detection of optic disc hemorrhage, subtle change in the neuroretinal rim, or vessel position. However, we are very busy. Ophthalmologists should think many things at the clinic. For instance, he or she should look at the optic disc, visual field, measure intraocular pressure, check compliance, other medical or ocular conditions, and determine the medication direction, sometimes consider surgery, and explain all those things to the patient. In very busy clinic, it is sometimes hard to do everything without making mistake. Publications also shows the assessment of even only optic disc notching was very variable among glaucoma specialists. So we have to acknowledge that consistent clinician's decision is less than we expect in reality. So I asked a similar question to the ChatGPT. Will OCT be mandatory for the diagnosis and follow-up of glaucoma in the future? And it says, American Academy of Ophthalmology preferred practice pattern guidelines recommend the use of OCT for glaucoma diagnosis and management. However, its use is dependent on the availability of OCT technology, cost of OCT imaging, and the policy and regulation or insurance of the healthcare systems. Next step for OCT utilization is how to incorporate artificial intelligence to match the advantage of human skill and quantitative OCT outputs, and maybe more than what we can expect they can do. So in summary, I'd like to conclude that OCT is not mandatory yet, but it allows objective and quantitative examination, and it becomes possible to approach RNA film, macula, ONH, vessel, and even lamina cribrosa. It aids classification and follow-up and supports the clinical decision-making along with other examination. But we have to be very careful and consider image quality and standardization issue when interpreting OCT result. Big data and AI will play a role for better use of OCT in the very near future. Thank you very much for your attention.
Yeah. I think Dr. Kyungrim is not here. Our next speaker, I'd like to introduce our next speaker, Dr. Devang Angmo. She's additional professor and consultant at Glaucoma Services at the RP Center, AIMS in Delhi. She'll be speaking to us on OCT-guided glaucoma surgery. Devang?
Thank you, Manisha. I'll be speaking on OCT-guided glaucoma surgery. So the introduction of OCT into clinical practice has brought a landmark change not only in the diagnosis, management, and also in the monitoring of nearly all ocular pathologies. And on the same lines, OCT integrated with the operating microscope has brought a paradigm shift in ophthalmic surgery. So during surgical maneuvering, the IOCT with a heads-up display, it allows rapid visualization of the area of interest and provides the surgeon with the information regarding the tissue surrounding the surroundings and the instrument tissue interactions. And also it is a very good teaching tool as well. So if you look into the various glaucoma procedures, the integrated OCT has helped with the bleb needling, bleb sparing epithelial exchange in transconjunctival suturing, to visualize the bang cleft, to visualize the AGV tube positioning, especially in cases of corneal opacities, and also OCT enhanced AIOS angiography. So if you look at bleb needling, so as we all know that bleb needling is basically a blind procedure where we insert this 26 gauge needle. And because of the finer resolution, OCT is able to present a detailed view of the bleb wall, the underlying sclera, and an accurate assessment of the location and the extent of the bleb structure. So this is the in vivo live view of the needle, and we exactly know which plane we are going, whether we are not going very deep, and therefore the complication rates in terms of hyphema and hemorrhage are very low. Also, it can be used for bleb repairs like bleb sparing epithelial exchange, wherein we remove the abnormal epithelium, that is the epithelium over the bleb. Thereafter, we advance the surrounding conjunctiva, surrounding healthy conjunctiva, without excising the bleb itself. So the problem is that in cases of blebs that are avascular, thin, cystic, the epithelium itself is not visible to the naked eye, and to see that we use the trypan blue dye, and along with the OCT, integrated OCT, we can peel off this epithelium in very easily without actually damaging the underlying bleb structure. Therefore, OCT with trypan blue is an adjunct to ensure the complete epithelial removal without causing any inadvertent damage to it. So this is a small video wherein we can see a huge avascular thin cystic bleb, and after dissecting the bleb 270 degrees and putting the trypan blue dye, we start a blunt dissection at one end, and as we can see that at the edges, we can still have a bite of the epithelium, but as we go centrally, the epithelium tends to be very thin, and that is when we have problem in dissection. The underlying bleb tissue is very friable and ready to damage. So if we just use the IOCT and peel the epithelium looking into, we are not going we are only superficial and not going very deep. So IOCT in that sense is like a third eye for us, which is giving us a 360-degree view of the bleb itself. We have also used the integrated OCT system to manage cases of early overfiltering blebs, patients who have good visual potential and has not improved on conservative medical management on steroids, both topical and oral, and we don't want to go and open up the bleb because the risk of fibrosis and failure is very high. So in these cases, transconjunctival suturing has helped because the integrated OCT helps to get the exact location of the scleral flap while performing the transconjunctival suturing. So this is where the OCT, the live OCT is. We can see how there are big cysts, and after putting 2 sutures, we can see the reduction in the bleb height as well as the cystic spaces have also reduced. So this is a small video. And while putting the important clinical pearl is that these blebs are usually overfiltering and very high. So as we are putting these sutures, we tend to get superficial. So if we have an integrated OCT system, we actually know that we are now in the conjunctiva. Now we are taking a bite in the sclera, and that is how it is helpful in putting these sutures. And these sutures, we can put multiple sutures, 3 to 4, and depending on the post-operative day 1 to 3, we can also remove them. It is totally reversible depending on the build-up of the pressures, and these patients have performed very well thereafter. Then OCT can also be used to visualize the bang cleft. So this especially as a teaching tool, this 3-o'clock hour bang has been done, and we can see here there is this white arrow which shows there is a good visualization of the bang cleft. and then we can do the I&A. And this we have done a post-operative OCT to visualize the bank cleft itself. In also IOCT, integrated OCT system, is a very good tool in cases where there is corneal cases of patients of glaucoma who have multiple failed surgeries and with corneal opacities which are not very dense and which have high pressures. So we want to put in a tube. However, we don't know the exact path wherein the place wherein the tube needs to be put. So using the OCT, live OCT, we actually know that the tube now has been put into the anterior chamber and more towards, if we look at the image here, we can see that it is more, the tube is more towards the iris than towards the endothelium. That place, then we want to, that place we put the tube, and then it confirms that the placement of the tube is correct. So in the OCT also has helped us in cases where it has also helped in cases in positioning of tubes where there are superior pass and the video itself is not running in this. Especially here, there was a superior pass and it was difficult to visualize the placement of the tube. So again, switching on the live OCT segment, we come to know where exactly we wanted to put the tube in the sulcus, and actually the tube has come in the sulcus or it has gone behind the lens. The OCT is very helpful in such cases. So next is the OCT guided aqueous angiography. So angiography per se is performed in the OT under supine position. So we modify the existing OCT known as the flex module. So this is how the system is. And with this a spectralis flex camera with a guided tracer like 0.25% ICG dye or 2% fluorescein dye is used. And it has been used in cases of to help to guide in cases of MIGS. So this work is done by Professor Dada at our center, and the video courtesy also goes to him. So in this video, so we prior to doing the bang, the collector channels are viewed, and in this is the nasal side, this is the temporal side. So where there is maximal flow, technically the mixed procedure should be performed in that area. So after visualizing that, the bang surgery is being performed, and thereafter at the end when we visualize, we can see that the maximum flow is in that area where the bang has been done. So to conclude, IOCT with heads-up display allows a rapid visualization of the area of interest and provides the surgeon with information regarding tissue surroundings and instrument tissue interactions. And because of its finer resolution, OCT is able to present detailed view of the bleb wall, the sclera, and an accurate assessment of the location and extent of the bleb structure. And this permits better visualization, easy maneuvering, and better dissection, and thereby reducing the risk of complications. Also, OCT enhanced aqueous angiography is the future for decision-making in mixed procedure. Thank you for patient listening.
Thank you, Devang. That was really a very interesting talk and nice videos. So it gives me, it's my pleasure to introduce our next speaker, Dr. Jinwook Jung, who is a professor of ophthalmology at the University of Seoul, Korea. And he'll be talking to us on the advances in OCT imaging technology, clinical applications in glaucoma. Jinwook?
Okay, thank you. Thank you very much for the invitation to the 2024 AIOS Asia Pacific Glaucoma Society Symposium. My name is Jinwook Jung. I'm from Seoul National University Hospital, Seoul, Korea. Today, I will talk about the advances in OCT imaging technology and clinical applications in glaucoma. This is my financial disclosure. I do not have any financial disclosure in the content of my presentation. And glaucoma is an optic neuropathy and with a selective loss of axons and death of retinal ganglion cells, and followed by visual field defects. And today, in the first part, I will talk about the glaucoma imaging with OCT, imaging deep ocular structure. In the biomechanical paradigm, the intraocular pressure has a very prominent role in the pathogenesis of glaucoma. High intraocular pressure and elevated intraocular pressure plays a role in the pathogenesis of glaucoma, and high intraocular pressure may lead to an LC posterior displacement and laminar cribrosa thinning. And this is our recent papers, and we assess the laminar cribrosa curvature and laminar cribrosa deformation, and with an open angle glaucoma incidence and the progression of the open angle glaucoma. And in this study, we use the new parameter LC, laminar cribrosa curvature index, and this is a novel and simple index, and for quantitative evaluation of LC posterior point. And using this equation, this calculation, we can measure the LC deformation here. And we are using the Strepsir's OCT, and we can measure the LC deformation and LC posterior bowing, and we can measure the LC coverage index here. And this is an example slide, and this is a healthy eye. You can see a laminar curvature here and here. There is no significant deformation. In normal tension glaucoma eye, you can see a significant deformation here. And in high pressure, high tension glaucoma eye, you can see a higher deformation of laminar curvature here and here. So this illustration indicates that this is a healthy eye, the laminar curvature is here and here. In normal tension glaucoma eye, you can see the laminar curvature displaces posteriorly and posteriorly. And in high tension glaucoma eye, the laminar curvature deformation even higher than normal tension glaucoma eye. So by using the OCT technology, we can measure this deformation quantitatively. And this is another study using the Strepsir's OCT, and we investigated the relationship between the degree of posterior bowing of the laminar cribrosa at baseline and the rate of subsequent visual field progression in glaucoma. In this study, we used this parameter. We measured the LC coverage here, and this is a scatter plot. And this scatter plot indicates that the high LC coverage and high significant LC deformation indicates a fast visual field progression here. And you can see a breakpoint here, and beyond this breakpoint, then higher LC deformation, you can see a significant, faster visual field progression. And this is an example case, and you can see this is a glaucoma case. You can see an RNF defect here and here. And in this eye, we scanned the laminar curvature imaging, and we can see a significant deformation of LC here, and we predict that this patient has a fast progressor, and we followed up these patients, and we can find this patient has a significant visual field progression here and here. So in this study, we found that the baseline LC curvature showed a significant correlation with the rate of subsequent visual field iteration, and this indicates that the greater posterior bowing of LC maybe means more vulnerable to further glaucomatous injury. And now let's move on to the next part, the early detection of glaucoma. And I will talk about these three topics here. And in the first topic is a wide field image in glaucoma. And this is an original OCT image here. We can have an RNFM map here. But recently, we can have a wider image here, including optic disc and macula. So by using this wide imaging, we can have a very clear infertemporal RNFM defect here and here. So by using the wide field image, including the macula area, the wide field image is more sensitive in visualizing the temporal margin of the RNFL defect. And also wide field image is more reliable and reproducible for the detection of progression or deepening of RNFL defect. And the next topic is an AI in glaucoma. And now AI, machine learning, and deep learning is a very hot topic in glaucoma research. And our group also did research, and we use a deep learning classifier to discriminate glaucoma and compressive optic neuropathy and assess the performance of deep learning classifier for the differentiation of these two diseases. And this case showed that, and you can see optic disc a little bit pale and diffuse RNF field thinning here, and significant visual field loss, and also diffuse RNF field thinning in here and here. So this case is glaucoma or some other optic neuropathy. Our deep learning classifier showed that this patient has a very low probability of glaucoma, so indicates that this case needs a brain imaging. And we did brain imaging, we found there is a significant supracellular meningioma in the brain. So this case indicates that the deep learning classifier can help us to discriminate glaucoma and other optic neuropathy. So this is our summary slide. And also the final topic is an adaptive optics of OCT in glaucoma. Adaptive optics can improve the performance of optical system, reducing the effect of the wavefront distortions. And so this technology can be used in the astronomical telescopes and microscopy and retinal imaging system. For example, this is a telescope image, and without adaptive optics, the planet Uranus, the image is a little bit not clear and a little bit vague. But with adaptive optics, we can have a very clear image of this planet. So we can use this technology in our retinal and optic nerve head imaging machine and devices. And by using the adaptive optics, we can increase the visualization of the LC microstructure and improve the current understanding of LC and its microarchitecture. And also, adaptive optics OCT, we can understand more clearly the structure function relationship in glaucoma, and we can identify early glaucoma damages at the cellular level, and we can easily monitor for the glaucoma progression. So this, in summary, my talk, in the first part, I talked about the quantitative assessment of deep optic nerve head structure, and the imaging of the deep optic nerve head structure may provide additional information when evaluating glaucomatous optic nerve head change. And LC deformation in glaucoma, and we measure the LC curvature using the OCT scans, and we identify the significant relationship between the degree of the posterior bowing of LC and the rate of visual field progression. And wide field image is also important and very useful. And the wide field image is sensitive in visualizing the RNF defects and reliable and reproducible for the detection of progression of RNF defect. And AI in glaucoma, by using the deep learning classifier, we can easily discriminate glaucoma and other optic neuropathy, like a compressive optic neuropathy. And adaptive optics OCT in glaucoma, the incorporation of the adaptive optics we can enhance OCT, improving image resolution and quality, and we can measure and we can visualize the segment of eye by using this technology. Thank you very much, and thank you for your listening. Thank you.
Thank you, Dr. Jung, for this wonderful talk. And with this, I would like to call upon our next speaker, Dr. Nazrul Islam. Dr. Nazrul Islam is a senior consultant and director of Bangladesh Eye Hospital. Over to you, sir. Over to you, sir.
Thank you very much. My slides are visible?
Yes, sir. You need to put on slide.
Yeah. Thank you very much. Actually, I'm grateful and thankful to AIOS for the opportunity. I am Dr. Nazrul Islam from Bangladesh Eye Hospital and Institute in Dhaka. I welcome all the delegates and participants in this APGS symposium. I do not have any financial disclosure. If you look to this slide, you see the structural changes in glaucoma seen in the color fundus photography, OCT ganglion cell complex analysis, and OCT RNFL analysis. At the same time, the function in the visual field analysis. So definitely we can correlate the structures seen in the glaucoma damage with the function in the glaucoma damage. If you look to the fundus photography, both the color fundus and the red-free photograph is important. Sorry. And you can see the measurement of the disc and cup always can be done from here. Yes.
Yeah, there's a black scotoma in the center of the screen. Is it there in your presentation?
No, not in my presentation, but I cannot see my video. I can see the video now. Okay. And not in my presentation. Maybe something from server.
Somebody from the
My presentation is fine.
Audio from somebody from the audio vision.
Sir, can you just stop share for a minute?
Sure.
When you click on share once, there is something called optimize. So just uncheck that. Just click on share once.
Unchecked. Okay, unchecked.
Now you that thing will go away now.
Okay. Now is it okay?
Yes, okay now.
Okay, thank you very much. So in the color fundus photography, you can see the agent rule also, which is present in 83% of eyes. In the OCT, we can see all the layers of the retina, and it is the really imaging objective way and quantitatively assessing the damage of the optic nerve head and the nerve fiber layer and also the macular complex. We can do the line scan, radial scan, circle scan, and the circle is done usually in the 1.73 millimeter from the disc. Usually we do the TSNI map, temporal superior map, to see the changes in the RNFL. Very important nowadays because ganglion cell analysis is very important, especially for the early glaucoma, when even the RNFL change is not present, BFA is not present. So we can see also is there a difference between the GCA analysis and also the RFA analysis in the same patient. OCT is improving, as Dr. Jean Book said, it is improving a lot. Now we can have swept source OCT having more than 1 lakh scan per scan per second and gives a good resolution. There's a printout of the swept source OCT, and I want to show this because you have many zones here to see to print out, but important is the reliability. For the structure, if you do not have the reliability, this image print is not valuable. So we always see the reliability is okay or not. And every machine has this code, like I showed at OCT in TopCon machine, out of 100, more than 45 strength should be there. In Zeiss machine, out of 10 should be more than 6. So every machine has its own strength. We should keep in mind that OCT changes can occur even in normal individuals. If you look to the study by Enar Kim, that normally people might have 26.2% of the changes in the RNFL. Again, another study by Wang et al. Showed two important points here. Even a glaucoma patient might not have changes in the ganglion cell complex. On the other hand, normal individuals might have false positive 21% in the RNFL and 15% in the ganglion cell complex. Again, more than that, in another study by Dr. Kim, I think Dr. Jean Book showed this presentation. And this study also showed that false positive they found in the normal individuals is 40%, and false negative RNFL is 30%. This is 40%. So it's really very high. So should keep in mind, even in the myopic fundus, all of us, we know that in myopic fundus, we find the glaucomatous kind of defect, kind of a red disease in the OCT, but these are not glaucoma. Even in the same OCT, in the ganglion cell complex and in the RNFL, if you have the same kind of defect, it increases our confidence of the diagnosis. During the visual field analysis, I'm not going detail, but in different zone, again, it is important to see the reliability index. Because if it is not reliable, you must repeat the test. Otherwise, it is not acceptable. So visual field analysis must be reliable and should be clinically correlated with the structural function. Regarding the sensitivity of the OCT and VFA, there is a report from Zenbo Zhang. They found that most of the patient, having 38% patient having sensitive in the OCT during the progression, are only 15% in the progression of the VFA. So definitely, OCT is better to sensitive than VFA in the progression of the disease. Regarding the central defect, we do 10-2 visual field, but it has only 12 points. But if you do 24-10, 12 points in the center, but in the 10-2 it is 68 points. So we can do 10-2 for the all early glaucoma cases. Newer software 24-2-C gives you better result, both 24-2 and also central scotoma. So correlation with the visual field is my topic now. And we have forum from ZEISS, is a glaucoma workplace that gives you sometimes the three structure, the fundus photography, OCT changes, and visual field analysis. So in this case, you can see the changes in the RNFL is equivalent to the changes in the, must see that it is a flipped change. It is not actually, it is a flipped. So you can see the opposite way that this inferior changes, you can see the superior field defect. Forum also in my institute also use forum, but we have software with two structure. One is OCT and visual field. So it is also very important to see the same screen. You can see very nicely this forum case that is also flipped. This one also flipped. So there is scotoma infranasal, there is supratemporal. So it is very important that all the features, the GCC, RNFL, BFA in the same screen. So it gives you better result to see the structure and function. Now I'll show some of the case reports and of my patient, and I've taken permission from my patients. So this is a patient had high intraocular pressure, 25, 26. Patient had no symptom, and definitely we did the structural color fundus photography, OCT, RNFL is normal, visual field also normal. The other patient, the patient had no symptom, no problem at all, but on examination, we found a large physiological cup. And so we did the OCT exam, visual field, it was normal. And we finally concluded, as you can see here, the disc diameter is 1.1 plus half diameter, disc diameter from the fovea. So it, of course, is a larger disc. So it has a larger cup disc ratio. It is a normal patient. In this patient, the patient had a little bit higher intraocular pressure, 26, 27, and a little raised CD ratio in the left eye, and corresponding changes in the RNFL, and there is no change in the visual field analysis. So definitely, there is structural change, but no functional, is a pre-perimetric glaucoma. In this patient, you can find obvious notch superiorly, and there is equivalent changes in the RNFL, in the OCT, but again, there is no change in the visual field. So we can say that it is also pre-perimetric glaucoma. In this patient, you can see both superior and inferior notching. Accordingly, there is some change in the RNFL and also changes in the visual field. So this is good correlated. And this patient had trauma. It is a traumatic angle recession glaucoma. And you can see here in the right eye, it is totally normal. But in the left eye, there is raised intraocular pressure, there is notching, there is change in the RNFL, thinning, and equivalent change in the visual field analysis. So definitely it's correlated. Structure and function is correlated. In advanced glaucoma, most of the time, IOCT correlates better. So it is advanced glaucoma with increased CD ratio. There is marked thinning, marked thinning of the RNFL in OCT and equivalent changes in the visual field analysis. So this is a acute angular glaucoma, post-angular glaucoma. You can see very increase in CD ratio, but shallow capping and equivalent or correlated changes, thinning in the RNFL and diffuse visual field analysis changes or visual field defect. But now I'm showing some report that is not correlated. Like in this patient, if you see, this patient is normal. Patient IOP is also normal. Visual field is also normal. But patient having some changes, thinning in the RNFL. So if you look more carefully, you can see here, the signal strength is 1/10 or 2/10. And as mentioned earlier, that in ZEISS it should be more than 6. So definitely it is not a reliable OCT printout. So we must repeat the test and patient should be under observation. This is again a wrong report. You can see here that the patient is having a large scar and patient having changes in the RNFL, but visual field is normal. But as the disc is again here, large disc, so it can be both, maybe have glaucoma, may have the large scar. So we must repeat the test. Patient should be under observation. In this patient, you can see it's not corresponding because this patient is having normal disc, normal RNFL changes, normal OCT, but there is some changes in the visual field. But we know that structure damage usually comes first. There are many studies that have been proved that structural damage comes first, then the functional damage. So here there is no structural damage. So, but there is some functional changes, so it can be something different. Our patient reliability is good here, not bad, but still we can repeat the test. The functional structure function does not correlate in this field. This is again the very end-stage glaucoma, acute angular glaucoma, post-acute glaucoma. You can see there is shallow cupping, but long, thin cupping, but definitely it's an increased CD ratio according to the changes in the RNFL, and there is very small, narrow tubular vision. So in conclusion, I would say that structure and function should be correlated. Otherwise, we cannot make the diagnosis. So as always say, should not be biased. We should always see the patient's color fluorescence photography, red-free photography, RNFL changes, ganglion cell analysis changes, central thickness, corneal thickness, intraocular pressure, and then of course we can go for the diagnosis and then correlate the structural function, we can have the diagnosis. Thank you very much.
Thank you, Dr. Nazrul, for the wonderful presentation. And with this, I would like to call upon our next speaker, Dr. Sunita Dubey. Dr. Sunita Dubey is the Head and Medical Director of Shroff Charity Eye Hospital. Ma'am, over to you.
Thank you. Can you see my screen?
Yes, ma'am.
Yes, so I would like to thank AIOS for the opportunity. So as we know, OCT is very useful complement to a good clinical examination. However, good understanding of technology is essential to utilize its full potential, and clinical decision should never be driven by OCT results alone. A good clinical examination is a must. So I will be presenting some interesting cases. This patient, 45-year-old male, came to us in 2010, 13 years back, with normal IOP, open angles. And as you can see, there were changes in the disc, the superior, in the right eye, the superior NRR thinning with superior RNFL defect, with the corroborative changes in the visual field. And in the left eye, there was inferior thinning with inferior RNFL defect and corroborative changes on the visual field. The diurnal variation was within normal limits. Over the years, the IOP remained normal. The patient was started on 1 PG analog. However, if you look at the disc photos over the years, you can see there was definite progression in the structure. And although the progression was very slow from May 2010 to April 2019, after 19 years, there was development of this RNFL defect. And then into 2022, there was development of this disc hemorrhage and enlargement of RNFL defects over a period of time. So there was a definite progression on the optic nerve and RNFL clinically. Similarly, in the left eye also, in 2022, there was development of these disc hemorrhages, both at the superior and inferior pole of the disc, and enlargement of RNFL defects. So the visual fields were advised, and the AGMs were stepped up. Although in the trend analysis, the progression was pretty slow. It was not very fast, but there were definite changes. As you can see in the event analysis, in the last 3 to 4 fields, there were changes, reproducible changes in the consecutive fields in the right eye as well as in the left eye. So in the left eye, the progression was slightly more as compared to the right eye, but there were definite changes. So the patient was progressing slowly. And similarly on OCT also, in the right eye only, there was progression. There was change in 10 micron of RNFL in the right eye, whereas in the left eye, it was more or less stable. So this is the progressive analysis on OCT. You can see changes in the deterioration in the RNFL thickness over a period of time. And in the left eye, it was okay. There was no remarkable change. So since the pressures were within normal limits, the patient underwent investigations for normal tension glaucoma, and the sleep study did show obstructive sleep apnea with restless leg syndrome. And also 24 hours BP monitoring was done, and which showed nocturnal dipping. Since the patient was diagnosed to have normal tension glaucoma, we did OCT-A also, and there was gross reduction in vessel density in 2 consecutive tests. However, as you can see, the signal strength was poor in the second test, and therefore the vessel density was less. But when we repeated the OCT-A with good signal strength, it did not show remarkable reduction. So the OCT-A did not show any reduction in the vessel density and perfusion density with good signal strength. So we had this paper which showed that the importance of good signal strength in association with vessel density and perfusion density measurements. And this case taught us that a good signal strength is very, very important if you're performing OCT-A, and a signal strength of 9 and 10 definitely shows good values as compared to signal strength of less than 7. Another patient who was showing some structural changes on normal intraocular pressure. He was a case of PACG and operated phaco trap a few years ago. And there was development of these disc hemorrhages with corresponding decrease in the RNFL over a period of time, which was reproducible. So we do get change patients who show changes with decrease in RNFL and development of disc hemorrhage, especially patients who have systemic problems with normal intraocular pressures. There's another very interesting case, again, a 55-year-old male who presented to us in 2019. He was pseudophakic and the vision was normal. And as you can see here, there was a very deep RNFL defect in the infero-temporal quadrant, which was close to macula, and with a corroborative changes in the visual field. So the diurnal variation was done, which was normal. It was done at RP center as well as at our hospital. But over a period of time, again, this patient showed progression. As you can see, in 2018, 9, 20, 21, 23, the patient progressed. And so the OCT also. So there was a difference of 10 micron over a period of time. And this is the 2023 OCT report, wherein both the eyes showed changes in the OCT. There's some progression. And here you can see horizontal raphe. So the central macular changes were remarkable. You can see horizontal raphe here. And this is the panomap analysis. And you can see the defects of RNFL and macular defects were in continuity and close to the fixation here. Again, this patient had some points in favor with NTG. The IOP recorded was less than 21. Visual field defects were deep and closer to fixation. And there was history of snoring, and the sleep apnea studies were done. So over a period of time, as you can see, this patient showed progression over field also. Earlier, it was just superior. Now, there are changes which appeared in the inferior quadrants also in both the fields. So patient underwent trap in both the eyes since he was progressing. And after trap, the right eye did pretty well, but the left eye, the pressure became high. The patient underwent needling also. And now patient is on 2 AGMs in the left eye. So diurnal variation is essential to rule out spikes of intraocular pressure. And sometimes we may be missing spikes and label them as normal tension glaucomas if we do not perform 24 hours diurnal variation. Another patient whose vision was tubular, 6/6, and he was not able to see properly. And this OCT, although we know that it has floor effect, but when you do this panomap analysis, you realize that the entire central visual field is also gone. And that is why, although the patient can read 6/6, but his vision is very poor and he's not able to read or perform day-to-day activities. This is another 27-year-old young male, and he came to us with sudden decrease in vision since 3 months. And this is the findings: the superior notch in the right eye with RNFL defect. And in the left eye, he was hypertensive also, he had CR view. So both eyes, he was diagnosed as JOAG with left eye CR view. And when the hemorrhages resolved, there was progression in the RNFL defect. So I think these findings in OCT are quite reliable, and they correlate pretty well with the clinical findings if you have good signal strength and the reliability parameters are good. OCT can also be used to diagnose or differentiate glaucomatous from non-glaucomatous optic neuropathy. And the pattern of RNFL loss and optic nerve topography may provide clues on differential diagnosis. So this is one of the patients who had the compressive optic neuropathy. You can see the disc pallor, but when you look at OCT at first glance, you can confuse it with glaucomatous changes, although it is the disc findings are quite peculiar in this. And you can see here the inferior loss is less significant. There is inter-eye asymmetry, very high inter-eye asymmetry between the two eyes. So the loss is monocular, and that make you suspect non-glaucomatous optic neuropathy. And again, the macular changes also, the other eye was absolutely normal. So alarming findings in young patient with IOP in low teens and macular ganglion cell damage only in one eye demands some other investigations like radiological investigations and detailed clinical history to rule out neurological causes. And this particular patient in MRI showed the tumor which was extending into the optic canal. So absence of RNFL loss in fellow eye, high symmetry between the RNFL measurements of the two eye, and extent of RNFL loss and thinning, it depends on the anatomy of the lesion. So as we know, we use OCT very often. It has revolutionized the diagnosis and monitoring of glaucoma, as it can detect the damage objectively and quantitatively, and it correlates very well with our clinical findings, although we should be aware of the artifacts and shortcomings of OCT and use it wisely in making our clinical diagnosis. Thank you very much for your kind attention.
Thank you, Sunita ma'am, for the very wonderful illustrative presentation. And with this, we would like to conclude our APGS symposium. So now all of our speakers and panelists are there. So with this, I would take the opportunity to speak a few words about the APGS. So I'll be sharing a few slides. Are the slides visible?
Yes.
Yeah. So so in conjunction with Asia Pacific Glaucoma Society, this
it's not in speaker mode.
It's not in speaker mode.
It's not in presentation mode.
Now it's
Now
it's there. Okay. So this program has been made in conjunction with the Asia Pacific Glaucoma Society. So a few words regarding it. The Asia Pacific Glaucoma Society's main focus is to encourage collaborative research, exchange skills and knowledge, share and assist ophthalmological colleagues, educate eye care workers. So it's a community. If you look, there are more than 12,000 members, and it's not only it does not constitute only the Asia Pacific Glaucoma Congress. It also has made APGS guidelines, mixed training, mixed online services, APGS instruction courses, satellite congresses, joint symposia also. And they would like to encourage membership from various institutes and encourage fellows and residents to get the memberships and its advantages. The executive committee, as we all know, that Professor Dr. S.K. Fang is the president currently, and so we all want to save this date for the Asia Pacific Glaucoma Congress, which is in Manila this year in May. And with this, I think I would like to invite all the faculty and the panelists for the discussion. Can we all unmute? So I think there are a few questions that are there. So I'll ask the first question is to Dr. Monisha. Dr. Monisha, what is the role of AIOS OCT in clinical practice?
Yeah, so I know I did present a lot on using it on blebs and the potential for use, but honestly, we're not really doing it as much because it's not available. We don't have predictors currently to do it so that we can predict future or early cases of failures. But we do in the clinic, especially now with the fact that from the ZAP and the analyst study, we know that we're not doing LPIs for patients, but there is a small risk for patients with some ASOC parameters or anterior segment parameters that have a risk for angle closures. For those patients that are not going for, who do not opt for an LPI, we keep it as a documentation because we need to, these patients are being followed up perhaps every year, every 2 years or so. So it's good documentation rather than just doing a gonioscopy, because there's a lot of variability, and the fact that we have an imaging documentation is good. So that's when we're doing it. And also, so sometimes even in those patients, say, if you do an ASOST, we find there's a large lens wall. You don't need ASO because unlike the posterior segment OCT, anterior segment OCT does not give you parameters like a printout. But what we tell residents is that you can just put a pen, on the lens wall and see how big it is, just to have an idea and not really have quantitative measurements. So sometimes in patients that have a very large lens and they have borderline IOPs and with early moderate cataract, we do counsel them if they want an early cataract op as well, because studies have shown that a patient, acute attacks is much higher in those patients with a larger lens fault. And then, so of course, it's being used in patients with opaque corneas, high IOP, tubes, to see whether it's functioning, whether it's blocked, and whether, not just the patency, but also the position of the tubes. And in terms of, I know I presented a lot on using it as subgrouping. At least in Singapore, we're not using it to subgroup. We use it to give us an idea of, so large lens vault, perhaps a cataract surgery would be preferable. But yeah, so I just like to know from the panelists as well, how often do they have any other indications? Oh, I just wanted to mention, because I thought it would exceed my time. I did say that we can use it for sublux lenses, but of course, in the event that you have UBM and ASOCT both available, the UBM is a better parameter to assess for subluxation. One, because it also shows you can detect subluxation, and two, it has the ability to show us zonular integrity as well, which is not possible with the ASOCT. Yeah, so anybody from the panelists would like to add as well on when do they use?
Well,
Dr. Sushma. Yes, ma'am.
Yeah, well, I agree that if I have to look at the subluxation, I would prefer a UBM to look at, because I can look at the zonules and amount of zonules that are lost, and I can plan my surgery better. As far as ASOCT is concerned, I think I would use it particularly for patients who after post-PI also, if I don't see a good angle opening. So to understand whether it is the iris configuration or it is the lens vault or what is causing the problem, so that again, to plan whether this patient would require an early lens extraction or I would concentrate more or maybe iridoplasty and things like that. That is where I practically use it for.
Does anyone actually use it to plan for bleb needlings or suture lysis maybe? Because we don't, as far as I know, we don't really do it, but I guess it has an indication there, perhaps.
Bleb sorry,
ma'am.
I would say for bleb needling, maybe for documentation, but my planning is based on the gonioscopy looking at the internal ostium. But to document how the bleb looks like or how much are the opening spaces, I would do a pre-needling ASOCT and a post-needling to understand whether it has actually helped. Similarly, if I'm planning 5FUs for these patients where the bleb is not very good or congested, I would do a pre and, over after 5FUs ASOCT to document that how good is the opening of the bleb or, the spaces in the bleb.
See, but one of the challenges in using it in a bleb is it's very difficult to register it to the same area. So since you're just getting a slice, you don't really get an exact comparison. So it sometimes makes it easier to just take a series of slices and see what happens.
I think that's what. Sorry.
Just like, yeah. No, sorry. No, just to add to Manisha's point about angle closure, I mean, it's much better if you're going to use an ASOC to document or to look for progression in angle closure. It's better to use a Cassia or something that gives you the entire 360 degrees, because the same issue happens there too. You can't really register your repeat images to the same slice.
Yeah, so I think with the Cassia, again for blebs as well, it's been shown that perhaps Cassia may be better, and I agree, but for documentation, because with the Cassia we have the ITC index, and that's more of a quantitative parameter that can be compared serially as well. I mean, just to add on to what Ronnie had said.
Any other question from the panelists?
Yeah, I have a question for Manisha.
Yes.
Manisha, what is your cutoff for lens fault? I know this is something that has been discussed.
Okay, so the thing is, if you use the Visante, the first version, second version, it's not really correlated, it's not reproducible. Cassia gives a different thing. So there's no cutoff value, but I think, and it doesn't come. So, if you have to get the lens fault, you've got to go to the machine, print it out. But what I tell is, it's the more you look, the more you realize it's a big lens and how much of the angles are closed. And so what I tell residents is, just have a look, put a pen across the spur and see how big it is. There's no real cutoff per se, because all the different imaging modalities have they're not interchangeable. The values are not interchangeable.
So I
But
think
anything above, so what we see is an angle closure. We do see above 1000 microns, so about 1 millimeter, whereas in open angles, sometimes it can be negative, but it's usually about 100, 200 microns.
So I want to ask question regarding my presentation, which I presented one case. I'm following up for 13 years. And as you must have seen, like there are changes on OCT and clinically also with the disc hemorrhage and RNFL defects. But OCT angio was normal with the good signal strength. And even visual field changes were there in the event analysis, very reproducible changes. So what I really not able to understand how to manage these patients. Clinically, it doesn't seem to be progressing. The trend line is almost flat. It is not steep at all. So what is the, kind of management, I think, since all are stalwarts here. So how do you manage such patients? And because we have done all possible investigations also. So
if Dr. Jin is there, it would be nice to have his opinion.
Yes.
Because they see a lot of you see a lot of disc hemorrhages, and I know that some of you think that they don't really mean anything. So
thank you. That's a very great question. And in Korea, we also have a lot of normal tension glaucoma patients, and many of our patients has a recurrent disc hemorrhage. And when we follow up these patients, we usually check their optic disc photography and RNFL, red-free RNFL photography and OCT and visual field as well. And so we think the looking into the red-free RNFL photography is a very good way to detect the structural progression. So if the patient has the recurrent disc hemorrhage, so we usually see the RNFL defects around the optic disc hemorrhage. And if the RNFL defects widening around the disc hemorrhage, we can easily detect the structural progression. So I think looking into the RNFL photography is very important, and the corresponding OCT findings and visual field changes, it can support those findings of progression.
Because these patients do not progress very fast, they're very slow progressors. So how do you, whether you would plan surgery or just step up the medication, so there's no need to even stay, very aggressive in treatment?
Yeah, so you mean your patients has the intraocular pressure is
normal?
Within
It is within
normal.
limits, yeah. It is
That's not high.
It's in fact in low teens. It's not even in high teens. Yeah.
Yes. So I usually use some medical treatment, and I consider change our medications or So I usually consider medical treatment on those cases.
So Sunita, I actually have a couple of patients who had recurrent disc hemorrhages because of systemic hypotension.
Yeah. Okay.
So sometimes a systemic evaluation, one of them had a mitral valve prolapse, and 3 occasions, repeated faintings, you saw disc hemorrhages. And she stayed stable for 15 years, but with an NFL defect.
If I may add, I was recalling one of my patients when you presented, again, a 40-year-old, and I detected again sleep apnea only after when he was progressing. Initially, I had done just cardiac evaluations, but he kept on progressing despite of normal pressures and sleep apnea. Now, actually speaking, he did not have much of breathing difficulty, so he was not on BiPAP. But after I detected progression, spoke to the physician, and they put him on BiPAP. And now it's been 3 years, he's not been progressing. So my medical treatment has not changed because his pressures were quite all right, but treating sleep apnea helped stabilize the progression in that patient.
How old was this patient, Sunita?
He was 52-year-old. And I have seen like if you send patient for sleep apnea study, most of the patients have some amount of sleep apnea. It is not very uncommon, and they are very uncomfortable with BiPAP. They are not comfortable, with the pipe. So I don't know whether you advise them to use BiPAP and CPAP. I don't know, because they are not comfortable and they don't snore that much. When you ask their partners also, they do not snore that much.
So I have a patient actually who sent me an email just today. They've repeated the CPAP, the test twice at 2 weeks interval, and one time it says definitely treat. One time it says So I don't know how to answer the question.
It's very dicey actually. Yeah, Sushmita, you're muted.
Look, Sushmita, yeah. We can't hear you.
Yeah, we can't hear you.
Yeah, we can't hear you, Sushmita.
Somebody from the AV can unmute or do something at the back end.
No, she's unmuted. There is no restriction. But मैम का mic, मैम audio settings में आपको एक बार mic को एक बार check करना पड़ेगा.
Okay.
Now audible.
Now you're audible.
All right. Right. So this thing of CPAP is very interesting with sleep apnea, is that there are actually levels of obstruction, and there are only certain types which can be treated with the CPAP. And sometimes the CPAP makes it worse. So if you have a really structural obstruction which needs surgery, and on top of that, you're going to give it a CPAP. So what I understand is the epiglottis falls back, and then if you put a CPAP on it, those are the patients who are really, really uncomfortable. So there are certain types. So sleep apnea is not one disease as glaucoma isn't. So if you have a lax velum, which is just not, is a little floppy, and then the CPAP moves it out of the way, those patients tolerate it well. So the 30% uptake of CPAP, as I understand, is because the patients haven't been evaluated well enough. So there's something called DISE, drug-induced sleep endoscopy, which has to be done. And for the sleep apneas which need surgical treatment, the CPAP is going to make it really, really worse. So it's not a one. So I think we need to really refer it to somebody who is well versed with sleep disorders before, it's not a one shot. It's like saying you should put in a tube for every glaucoma. That's not true. So that's the take. And this is a personal thing because I am on a CPAP now. So I have the kind which responds to CPAP, and I'm very, I sleep much less in conferences now. I'm wide awake.
Sleep apnea is something which is probably overlooked and underdiagnosed.
Yeah.
The reason is that there's no clear-cut guidelines. They may be, but I think they're not clear actually. And also, as Sushmita was saying, that there are different levels of sleep apnea. So I have a feeling that I think we are missing some of these cases because, I have seen like Sunita was saying that, you investigated the patient only after, the person starts deteriorating. So we kind of wait for some trigger of that kind, before we start thinking that, okay, what else? So sleep apnea actually comes at what else category? So it doesn't come before that. So I think if you are regularly asking them history, some way to suggest snoring or otherwise, and if is higher than what we detect in the clinics.
Okay, thank you everyone. I think with this, we need to conclude our session because I think I've been prompted by the organizers to finish the session. We've exceeded the time by 2 minutes. And can I just request the audiovisual to take a screenshot of all the speakers and the panelists?
Done, ma'am.
Okay, thank you so much. Thank you everyone.
Thank you everyone. And I hope the participants have taken home some good clinical, skills and understanding. Thank you very much, everyone.